Hello, and welcome to the fourth section of Airway Management, Chapter 12. We're going to get started on airway obstructions. As always, this is Keith Widmeyer with Wayne County EMS. We're going to get started today, starting the section out with foreign body airway obstructions. Foreign body airway obstruction, or FBAO, is a partial or complete blockage of the conducting airways due to a foreign body. For example, a piece of food bleeding into the airway or vomitus can block the airway. If an obstruction is not cleared, the heart, brain, and other organs of the body will be deprived of oxygen. When the heart stops, a patient is said to be in cardiac arrest. The longer the heart goes without oxygen, the greater the likelihood of cardiac arrest. The longer a patient sits in cardiac arrest, the less likely the patient's chances of survival. In addition to cardiac arrest, the patient can suffer an irreversible brain damage due to lack of oxygen. Excuse me. A foreign body airway obstruction can also result from a cardiac arrest. When a person becomes unresponsive, the jaw and tongue relax. Tongue falls into the back of the throat, obstructing the airway. Consequently, the tongue is the most common cause of an upper airway obstruction in an unresponsive patient. In a breathing patient, snoring, respirations can be heard when the upper airway is partially obstructed by the tongue. Loose dentures, vomitus, or trauma to the head, face, or neck also block the airway. You may be able to correct an airway obstruction caused by a patient's tongue by properly positioning the patient's head and neck to open the airway. Signs and symptoms of FBAO, or foreign body airway obstruction, depends on the following: the size of the foreign body, what the foreign body is made of, where the foreign body is located, how long the foreign body has been present, and if the obstruction produced by the foreign body is partial or complete. In adults, an FBAO often occurs during eating. Meat is the most common cause of an obstruction. Older adult patients who have difficulty swallowing are at risk for an FBAO. Choking in an adult is often associated with the following: attempts to swallow large, poorly chewed pieces of food, alcohol utilization, or loose or poorly fitting dentures. Most episodes of choking in infants and children occur during eating or play. The FBAO in children is often caused by the following: small foods such as nuts, raisins, sunflower seeds, popcorn, also poorly chewed pieces of meat, grapes, hot dogs. It's kind of funny that they had to separate meat and hot dogs, isn't it? Raw carrots or sausages. Items commonly found in the home, including disc batteries, pins, rings, nails, buttons, coins, plastic or metal, toy objects, and marbles. I cannot tell you how many pieces of various toys I have had to pull out of my children's nose or mouths. A patient who is alert and talking clearly or crying without difficulty has an open airway. If you suspect a foreign body airway obstruction, but the patient is responsive, can speak or make sounds, and can cough forcefully, he has a mild airway obstruction. You may hear wheezing between coughs. During this situation, it's best to encourage the patient to continue coughing. If the patient is unable to speak, cry, cough, or make any other sounds, he has a severe airway obstruction. Death due to suffocation will follow rapidly if you do not take prompt action. Signs of severe airway obstruction: high-pitched noise or inhalation. The scarier sound is no sound at all. You may also difficulty breathing, speaking, or they may be unable to speak. And you may note cyanosis, beginning with peripheral cyanosis, which is in the fingertips. You may note some cyanosis around the lips and around the orbits as well. Clearing the airway. So how do we manage those foreign body airway obstructions? The removal of a foreign material from the airway is critical for patient survival. Manual techniques that may be used to clear the foreign body airway obstruction from the upper airway include back slaps, abdominal and chest thrusts, and finger sweeps. Again, on the finger sweep idea, I personally do not like putting my fingers in patients' mouths. Finger sweeps are used to remove material from an unresponsive patient's upper airway. If you see foreign material in the patient's mouth, you must remove it immediately. A finger sweep is not performed on responsive patients or unresponsive patients who have a gag reflex. To perform a finger sweep, if the patient is uninjured, roll her to her side. Wipe out liquids from the airway using your index and middle finger covered with a cloth, and remove solid objects using your gloved index finger positioning like a hook. Use your little finger when performing a finger sweep on an infant or child. Suctioning is a procedure used to vacuum vomitus, saliva, blood, food particles, and other material from the patient's airway. Suctioning requires the use of a device that creates negative pressure. Suction units can be manually, electronically, or air-powered. Most suction units are inadequate for removing solid objects such as teeth, foreign bodies, and food. Mounted suction devices are built in on ambulance walls and are usually powered by the vehicle's battery. Mounted suction devices are also called fixed suction units. They provide a vacuum that is strong and adjustable. The parts of the suction unit that come in contact with the body fluids are disposable. Disadvantages of mounted suction devices are they are not portable and cannot be used with an alternative power source. Battery-operated portable suction units are often used in EMS systems. They are lightweight and generally have good suction power. Suction unit may be checked daily to make sure it is functioning properly. Because most of these devices use rechargeable batteries, it's important that the suction unit be kept charged when not in use. Over time, rechargeable batteries will lose the ability to hold a charge and need to be replaced. In most battery-operated suction units, the parts that come in contact with body fluids are disposable. However, in others, the parts are not disposable and must be cleaned out after each use. For the most part, in this area, we generally utilize all disposable materials. Hand-powered devices are lightweight, portable, and reliable. They're easy to use and relatively inexpensive. To create a vacuum necessary for suctioning, hand-powered units may be pumped or squeezed. This limits the length of time suctioning can be applied. The collection chamber of a hand-powered device is small. This limits the volume that can be suctioned. Suction catheters may be rigid or soft. Rigid suction catheters are able to quickly suction large amounts of fluid. A rigid suction catheter is also called a hard suction catheter, a Yonker catheter, a tonsil tip catheter, or a tonsil sucker. Use a rigid suction catheter to remove secretions from the patient's mouth. Soft suction catheters are called flexible, whistle tip, or French suction catheters. These catheters are used to clear the mouth and throat. ALS personnel may use soft catheters to remove secretions from tracheal tubes in intubated patients. Soft suction catheters are available in many sizes. The inside diameter of a soft suction catheter is smaller than that of a rigid catheter. When suctioning a patient with a rigid suction catheter, insert the patient into the patient's mouth no deeper than the base of his tongue. To suction the patient's mouth with a rigid suction catheter, turn the power of the suction unit on and make sure it's working. Attach the suction catheter. Without applying suction, place the tip of the catheter into the patient's mouth, gently advancing the catheter tip along the side of the mouth. Insert the catheter tip no deeper than the base of the tongue. Apply suction while moving the tip of the catheter from side to side as you withdraw it from the patient's mouth. Because you're removing air from the patient when suctioning, do not suction an adult for more than 10 seconds. I know it says 15 on here. I'd prefer you to go with 10. When suctioning an infant or a child, do not apply suction for more than 10 seconds as well. Because the suction can cause serious changes in your patient's heart rate, you may observe your patient closely when performing this procedure. The patient's heart rate may slow or become irregular due to lack of oxygen, or if the tip of the catheter stimulates the back of the throat or tongue. These changes in heart rate can occur in any patient, but they are particularly common in infants and children. If the patient's heart rate slows, stop suctioning and provide ventilations. The recovery position involves positioning a patient on his side. This position can be used to help maintain an open airway in an unresponsive and uninjured patient who is breathing adequately. In this position, gravity allows fluid to flow from the mouth and help keep the airway clear. Follow these steps to place a patient in the recovery position. Raise the patient's left arm above his head and then across the patient's right leg over his left leg. While supporting the patient's face, grasp his right shoulder and roll him towards you onto his left side. The patient's head should be as close to a midline position as possible. The patient's head, torso, and shoulders should move at the same time without twisting. Place the patient's right hand under the side of the face. Continue to monitor the patient until additional EMS personnel arrive and assume care. Emphasize that a patient with known or suspected spinal injury should not be placed into a recovery position. Some experts recommend that an unresponsive patient who has a possible spinal injury be positioned in a modified recovery position. In this position, one of the patient's arms is extended above his head. The patient's body is rolled to the side of his head and rests on the extended arm. That is the end of Chapter 12, Airway Management.